I'm going to start the recording and welcome. I'm Rob Schwartz, and I am the lead of the Collaborative Specialization in Public Health Policy. We host these public health policy rounds each month during the academic year, and they are open to the general community at University of Toronto and public health policy folks outside of U of T as well. And they also serve as a course for our students in the collaborative specialization. We have a pretty strict format that we've been following for years, and it seems to work online just as well. The keynote speaker is given up to 35 minutes, followed by a faculty discussant and a trainee discussant, each for 5 minutes. The keynote speaker may choose to respond to the discussants after their remarks. Then we go to the audience, and we start with questions and comments from the trainees in the collaborative specialization are given first chance. And I just remind the trainees that you're actually expected to formulate questions and comments and to participate in that way. And then we open the floor generally. So we run until 2 o'clock. And I'd like to start with a land acknowledgement. We would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalla School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. I'd like now to introduce our speakers. We are delighted to have Dr. Sara Allin, a colleague at the Institute for Health Policy Management and Evaluation. And congratulations, Sara, on your recent appointment to a full-time regular tenure track position. We're delighted to have you on board. So Sara is an associate professor of health policy, and she is the director of operations of the North American Observatory on Health Systems and Policies. Her research focuses on comparative health systems and the intersection of policy and practice within Canada and internationally, with current areas of focus including public health systems, long-term care, and primary care. So who could ask for a person better suited to speak to public health systems at this time of COVID? It should be really fascinating. Very unusually, today I am the faculty discussant. And I think it's the first time I'm ever doing this, and it had to do with a little glitch in communications. And so I will introduce myself as the discussant. I am, for those of you who may not know me, I am a professor in IHPME as well as in the Social and Behavioral Health Sciences Division. I spend most of my time running the Ontario Tobacco Research Unit and also conducting public health policy research having to do with strategy, design, and evaluation. Leave it there. I'm also really happy to introduce Harman Sandhu. Harman is a PhD candidate in the Institute of Health Policy Management and Evaluation. Before his PhD studies, he held positions in the government of Ontario. And amongst the things he did there was leading race-based data analyses at the Anti-Racism Directorate. He also disseminated research in the Ministry of Municipal Affairs and Housing and managed projects to the establishment of the Ontario Health at the Ministry of Health. Harman has researched and published peer-reviewed articles in the fields of mental health stigma, smoke-free policies, cannabis legalization, and faculty diversity. He's passionate about networking and mentorship and believes strongly in continuous learning and growth. So delighted to have you as our discussant today, Harman. And full disclosure, both Harman and myself are somewhat involved in the study that Sara is presenting today. It is a bit of an insider's discussant team today. It's sort of an inside-outside in a way. And without further ado, I'm going to hand it over to Sara. I know that she has slides to share as well. And please, those of you who are able, please do share your faces, your videos. It really makes it a lot more pleasant when the speakers have people to look at. That would be just delightful. Sara, it is all yours.
Thank you. Can you see my slides okay?
Yes.
Great. Thanks, Rob, for that great introduction. I'm really excited to be here to present this work in progress, to engage with this insider and outsider group in discussion. And I'll be talking about the systems of public health. That includes their governance, their organization, finance, as well as workforce across Canada, and sharing some emerging findings on how these systems impact the COVID response, drawing on case study underway in Ontario. And I'll have to come back maybe in another phase of this rounds, maybe next year, to talk about the results from multiple case studies. That would be great to sort of learn from the comparative aspect of this that we're really excited about, but I'm not quite ready to share some of those, unfortunately, today, but I'll give you some insights from the first case in Ontario. So I'll move it to my next slide. I'll just acknowledge my research team, including co-principal investigators that are Laura Rosella and Andrew Pinto, as well as co-investigators, our postdoctoral fellow, Rob Smith, research coordinator, and research assistants, who all work really nicely as a team to make this work possible. And I've really enjoyed working with everyone. I'm really grateful to key informants in Ontario and Quebec who so far have spent incredibly precious time speaking with us and speaking so openly with candor and thoughtfulness that must be the most challenging and stressful time in their careers, and yet they agreed to spend time with us answering questions and conversing with us about their experiences, so the case study work wouldn't be possible without them. Thanks also to CIHR for funding this work. Really grateful for that support. So in today's talk, I'm going to be covering two broad questions. The first is, how can we characterize the public health systems across the provinces and territories? And the second is, how do these systems shape the provincial and territorial COVID-19 responses? This is a work in progress, as I mentioned, but the overarching hypothesis is that there are pretty big differences in the way public health systems are governed and organized across the country, and that these differences will have some meaningful impact on the decision-making process in the pandemic. So which public health interventions are chosen and when, with what effects and effectiveness. So this, I'm really looking forward to discussing this with you, hearing your questions, comments, critiques, because it is a work in progress, and I'm hoping this will be a good learning opportunity for me as well. So the first question is about characterizing the public health systems across provinces and territories in Canada. And this is where we've spent the bulk of the sort of first year of this one-year project trying to understand. And it's incredible how much of a learning curve this is to really dig deeply into each of the provinces and territories' public health systems and try and compare and contrast these across the country. But first, what does it mean to study the public health system? One way to look at public health is through the lens of what the WHO describes and defines health systems as all those organizations, institutions, et cetera, that are devoted to producing health actions, and where health action includes the personal health care, as well as public health services, as well as intersectoral initiatives with the primary aim of improving health. And this is the definition from the World Health Report 21 years ago, really defined how we think about health systems to this day, identifying its core components or building blocks and evaluating performance. And public health is really core component of public health systems, but due to the sort of pretty fundamental difference in perspective of public versus personal health, so that it's care for populations versus care for individuals, it's argued that simply embedding public health within a public health system may miss some of the important sort of considerations of public health that are unique, that might require its own sort of analytic separation. And so there's been some effort to try and define what a public health system is. Not as much attention to developing health system frameworks, of which there are hundreds, many of which are really inspired by and closely related to WHO, but the work to define and understand what a public health system is much more limited. But a recent great review paper led by Tamika Jarvis, who's a PhD student at McMaster, she reviewed the literature with her colleagues to really develop a conceptualization of public health system. They found in this comprehensive review that there are about 10 unique definitions out there of public health system, and then they sort of propose their own definition. And I include here this conceptual framework from their paper. And what I like about it is that they identify this sort of these two systems, healthcare and public health, that have an overlap, and they're all within a broad health system, but they can each be examined through the lens of the sort of functions as well as system arrangements, including governance, organization, financing, but that an additional dimension is required when focusing on public health, and that is partnerships, which are really critical to the way public health functions. So much of the literature they found is really identifying what are those core functions of public health, as opposed to identifying it sort of as a system. And here I've just put the WHO definition of the functions of public health, those that are core, that are broadly health protection and health promotion, but listed here in its commonly referred to buckets. And they also outline the enabling functions, which are similar to the health system arrangements around organization, financing, and workforce. So this helps us to sort of identify how we might look to understand how a public health system is organized, and it helped to inform our work. And so to characterize the public health systems in Canada, we look to these 4 dimensions, that is the governance, organization, and workforce, and financing. And within each of these, I've included here a sort of a subset of the questions to give you a sense of what it is that we're looking for, how we've structured our work, and sort of collecting data along all of these dimensions. So for governments, we're concerned with what are the rules underlying public health, how are these tracked and monitored, and how are these enforced? With regard to financing, I'm interested in the size of the budget, how the decisions are made around defining the budget, and sort of where the sources of finance are. In organization, this is really who are the main actors, how do they relate to each other, considering the different levels of the system and mechanisms for coordinating sort of across those levels, as well as partnerships across sectors and within and with the healthcare system. And then the workforce, that is sort of the core public health workforce, can be defined as the staff that are involved in public health activities, and they identify public health as being their primary role. It's kind of a narrow definition, so it would exclude professionals like community pharmacists, midwives, GPs, who may play a role in promoting public health, but only as part of their overall job. So this is sort of how we've structured the way of looking across the country to understand public health. So in the next few slides, I'll share some of the findings from our reviews of public health systems in Canada that we're compiling based on publicly available information. We're working on writing working papers that we're in the process of sort of validating with experts in public health practitioners, and we'll aim to publish these in consolidated form. But these are, still very much work in progress. But I'm sharing some of the findings as we start to look across the country and see some of the common features and some of the unique features as well. So it's important to note that the federal government plays a unique and important role in public health, both in a lead role through, for example, the Quarantine Act, but also in a coordinating role and providing sort of guidelines and leadership through the Public Health Agency of Canada. Also, Indigenous governments play a key role in the health systems that they responsible for and govern for their populations. But here I'm focusing on the provinces and how they govern their public health systems. And generally, we see across the country, the provincial governments provide the overall direction, are responsible for the legislation for public health. And then, how this plays out is a little bit different in each. So the public health acts can be compared, and some work has been done to do that, to see how extensive they are in terms of capturing all of the core functions of public health. And it seems that the more recent renewals of public health have a broader sort of conceptualization of public health and include sort of the full range of public health functions, whereas the older ones tend to be more limited. Also, what's unique in Quebec is the Public Health Act has these unique requirements for an intersectoral action, for evaluating, conducting health impact assessments of all government legislation, which is sort of unique in Canada. We also can look to the role of the top doctor, the chief medical officer of health, which is commonly the term that this role has. And there's been some attention paid to the variation in this role across the country so far, led by Patrick Fafard, where they've found that there's sort of 4 broad types of scientific leadership held in this chief medical health officer role as defined through legislation, with variation in the roles of management, of public reporting and advocacy, and their advisory role to government, as well as how independent they are from government. So they identify quite a wide range in sort of these leadership types across Canada. We see some of the variation in sort of how this role is, the role played by this top doctor in setting the sort of overall guidance, overall vision for public health in the province. We also see quite a wide range in the approaches taken to sort of monitor performance, to, the direction is set, the legislation and the rules around public health are set, but then how are we monitoring the sort of performance of public health, or at least the effectiveness of the programs and so on. And it looks different in each province, where some provinces have a sort of broad public health plan and vision, like Quebec's currently in the middle of a 10-year plan, public health framework that's developed by the Ministry of Health and partners. And similarly in BC, they established this guiding framework for public health that summarizes the province's vision, the goals and the framework that they're using to assess and monitor achievement towards those goals. Whereas other provinces like Ontario and Nova Scotia have set public health standards that sort of set the framework for how public health providers are to report on their own programs and services, with room for local adaptation. And then there's a different approach, which is embedding public health system reporting within the broader performance reports for the whole health system. And so there's sort of a blurry line between what is considered public health versus the health system as a whole. So we see some variations here in governance that, take different shapes and forms across the country. But we see even more variation in sort of organizational structures. So there's some differences in terms of what's considered core to public health across the provinces and territories, and the extent to which some programs and services are the responsibility of ministries of health versus other ministries. But we also see a pretty big difference in the extent of the sort of organizational structure of the system. That is, the extent of authority held at different levels of the system and the relationship among these levels. So we do see in all provinces there's delivery of public health programs and services at the local level, yet the responsibility for planning public health varies. And we broadly see these 3 types of organizational structures that I list here on the slide, starting from the most recent type that has emerged since the late 2000s, which is a centralized administration of public health within an arm's length authority. That would include Alberta Health Services, as well as Nova Scotia Health Authority, Northwest Territories Health Authority, Saskatchewan, et cetera, where this arm's length provincial or territorial health authority is separate from government, has responsibility for administering and funding all acute and public health care services. So there's a hierarchical organization in the sense that there's sort of a reporting structure from the local sub-provincial geographically defined zones or regions up to the central authority level. The second model that we see is sort of what we've saw emerge throughout the 90s through regionalization, where most provinces shifted responsibility for the planning and delivery of health services to these locally sort of geographically defined regions. This included responsibility for health services, including public health, in an effort to sort of better integrate health services across the care continuum to improve efficiency, contain costs, and address some inequalities across regions. But there also was stated aims of, taking a population health approach to planning by bringing in public health expertise into healthcare planning and administration. There would be some better capacity to actually reallocate services or funding to better meet the needs of the population, informed through population surveillance and needs assessment, et cetera. And so we see this, major shift. It's been studied to some extent, but there's limited evidence of any impacts of this on the stated objectives. Little sign of any real reallocation of resources either. So we see a third model of local administration that's really what it's currently in Ontario, but all provinces had this model historically. And we see sort of a broad range of how this plays out in Ontario, but the local government takes this responsibility for supporting some of the financing, but also taking a leadership role in sort of being responsible for public health at the local level. So we'll spend some more time on the Ontario case in the second part of my talk. But first, I'll just provide a few sort of findings on the financing side where we see some different trends, but also some commonalities where roughly public health makes up less than 4% of Ministry of Health budgets. So this is perhaps one of the reasons why there hasn't been as much literature and research done on the public health system, because it is such a small component of the budget. And yet it's, it's rich for sort of understanding how these different structures and the approaches taken can impact the population and some of the objectives of public health. So there, we see a range of sort of the allocation of Ministry of Health budgets to public health, with, quite low in Quebec to the highest seems to be around in BC among the provinces. And there's some trends that seem to be going in different directions, with a slight increase in the last sort of 10 years in Ontario, from like 2.2, we're talking about a pretty small increase, and a slight decrease in Quebec, notably from the pretty significant budget cuts in 2015, and relative stability in BC. We also see it's common that provincial general revenues are the main source of finance for public health. And the exception again is Ontario, where there's a shared model of finance for much of public health services. So municipalities spend at least 25% of the local public health budgets. Provinces the Ministry of Health supports up to 75%. And interestingly, there's this sort of consideration in several provinces of changing the method for allocating resources to public health, but mostly the budgets are determined based on, population size and historical budgets. Though in at least 3 provinces, there have been expert reviews and commissions and even piloting of more sophisticated population-based needs resource allocation formulas for public health. And so, there's been at least some acknowledgement of the potential impact of this, or the potential benefits by shifting the resource allocation formula, but not much has been studied, at least to date. I was also really interested to learn about how at least in Quebec, there's been some use of earmarked taxes. So that is identifying a subset of taxes that can be earmarked or, directed towards public health. And that's been the case in Quebec, but that ended after a short time, using tobacco taxes to fund some tobacco public health programs, cessation programs. In the workforce, it's kind of a black box. There's limited data, limited information on the public health workforce across the country, with the exception of public health physicians, that is the physicians with specialization in prevention and public health. And we see some variation across the country with sort of one public health physician per 100,000, one physician per 100,000 population in Ontario and Alberta, and it's closer to 2 in Quebec and Manitoba. So it's there's some difference there, but we know that these make up the a small part of the broader public health workforce. There's also really limited use of any evidence of any kind of public health workforce strategies in place in the provinces. And we were only able to identify one review of the workforce in any province, which was in 2005 in Ontario. And here are just some of the findings that they found, some of the challenges that then were echoed in another review of the public health governance more broadly in 2017. Challenges around recruitment, lack of critical mass, especially in the smaller units. So it's really an area where there's minimal data to draw upon, at least in the published realm. So I'm going to turn it over to sort of shift gears. As I mentioned, this is really a work in progress, so I'm not going to be able to really leverage this potential for learning about the impacts of the different structures across Canada, but rather focusing in on one case in particular. So the question is really how these structures have impacted the public health, the response to the COVID-19 pandemic. And the approach that we're taking is through these multiple case studies. Data collection is currently underway in Quebec, but we've completed in Ontario, and then we're moving on to Alberta, 3 of the provinces that are most populous and have the most sort of impact by the COVID-19 pandemic, and also reflect different organizational and governance structures in Canada. So we developed an interview guide. Originally, this was intended to focus on how public health systems have been changing in recent years and what impacts those changes have had. And then with the pandemic, we sort of shifted the interview guide to add a component that is focused on COVID-19, given that we were interviewing people with leadership positions in public health. So this includes active, currently, and former leaders in the public health system with variation in geography and their discipline. What we've done is we've shared the sort of working paper that describes the 4 dimensions of public health within their jurisdiction in advance of an interview, and then have an open-ended, semi-structured interview based on these dimensions, as well as experiences during the pandemic. So who did we speak to in Ontario? We were really fortunate that we were able to speak to about 18 people in public health units, organizations, or public health related government portfolios. So with some diversity across the province in terms of geography, in terms of the type of governance model, and that's really how the public health unit fits with the municipal government varies across the province. And so we tried to get a reflection of different models, different levels of the system with 15 local and 3 provincial, different perspectives of discipline, as well as roles as senior leaders versus directors, managers, and others. So I can share with you some of the emerging themes from our preliminary analysis of the Ontario interview data, with a focus really on that COVID questions around how the public health systems, that is all those dimensions I mentioned, how do those impact the experience of public health leaders and practitioners in managing the pandemic. So I'll speak to some of these themes. I have lots of quotes, but that's where we're at. We haven't synthesized as much, and but I'm looking forward to hearing your reactions. So the first theme that emerged is really relating to the state of health system sort of reform or transformation currently underway at the time that the pandemic hit. So this is the consolidation of the LHINs into a super agency. And this quote really speaks to the challenge of being hit at this particular time and having to kind of pull people together in the absence of any kind of formal mechanism for doing that. So this key informant spoke to the fact that the LINs were dismantled without a system in place was a huge drawback, huge obstacle at the start of COVID. But again, we just thought, well, okay, we're going to rely on the relationship we've just recently been building as a new public health unit, and we'll pull in anyone and everyone that we think needs to have a say in some of these decisions that we need to make as a system with respect to containing COVID. And so that's what we did. So it really sounds like a, the lack of the formal structures that forced the leaders to have to sort of scramble to make, to put in the groups needed to make decisions for their regions. The second theme was about some of the some findings I mentioned earlier around other reviews where there's this lack of sort of capacity in the workforce, surge capacity, limited investments that had been made to information technology, as well as some degree of competition over the workforce, the talent pool across public health units. So this key informant speaks to chronic years of underinvestment in public health that definitely impeded our response. So we were using paper charts pretty much up until the summer to do thousands of case and contact management. So you can only imagine how difficult it is to achieve effective cluster investigations or case management when all your systems are very manual. So that in times of emergency, there's no surge capacity or very little from a public health workforce point of view. So this, put this context of how the lacking the structures to sort of do effective data management, whereas other key informants spoke to having to, negotiate for new personnel where people across the public health units were sort of competing for the same personnel, the same resources. And some could offer higher pay than others. And so this also impacted the ability to sort of ramp up when needed to manage the pandemic response. Another theme was around the limited support or leadership at the provincial level. So having to sort of make decisions locally and to compensate for some of the limitations that were seen at the provincial level. So this key informant noted that what's been very obvious for me is that the Chief Medical Officer of Health has no independence and very few staff that report to him can actually do any of the work. And so the gradual whittling away of that role over time has resulted in the kind of structure that we see now. And I think any public health physician in that role would struggle. They're not allowed to speak without going through all of the approval processes right now, and they're not being given a large enough staff to be able to basically respond. So this role of the Chief Medical Officer of Health has been, critiqued in terms of being able to support the public health leadership locally. And other key informants spoke to how their this sort of guidance and the decisions being made provincially were coming too late, and they had to sort of make decisions early on that sometimes went at different time from what the province had recommended. And, this created sort of some confusion, and they were seen as being out of step. Another theme that came out was around the ineffective use of financing during the pandemic and how this was inefficient. Again, talking about contact tracing and the management system there. So this key informant mentioned that they introduced the new case and contact management platform, moved away from IFIS. There are significant upstart costs to that in terms of not only the investment, which the province is bearing, to be fair, but to the orientation, training, monitoring, quality assurance that goes along with making sure our people, members of our team, are utilizing those tools to the best of their ability and what they're intended for. And so I think those are really the big markers for where the vulnerability in the system is. So there was extra costs being borne by local public health units in the absence of, sufficient support from the province. Another theme related to this jurisdictional crevasse that really affected Indigenous communities particularly. And this key informant spoke that if new funding is going out province-wide, our communities are Ontario citizens. And maybe it should be that the feds are giving us IPAC funding and money for our nurses, but it can't be, well, the feds are doing it, we're not going to do it. We should be working along the lines of Jordan's principle in all our work. And this theme came out in other interviews as well, where there is this ability, there was lack of access to information systems that allowed for data to go across Indigenous communities to other public health units, requiring duplication of work and inefficiencies as well. So I've spoken mostly of these challenges that the key informants were telling us about, the ways in which the system had created or, made things challenging during the response, but there were a few sort of themes related to these enablers that we sort of, the strengths of the system that were seen as enabling an effective response. And this broadly we summarize here by this not succinct summary of the theme, which is around the strong links to communities, but also strong links that had been forged with other public health units to allow for sort of coordinated, contextualized intersectoral action, as well as some sharing of resources. So there's one key informant spoke about the North, and there are 7 health units in the North, 5 of which are in the Northeast, because of the work that we did collectively to really rigorously think about how we would function if we were one region. I think that served to really strengthen and further fortify our relationships. And so, we have good relationships anyway. We sort of figured out, but that really helped us then come the pandemic to say that we have those stronger relationships to meet more frequently. So other key informants spoke about relationships with other public health units like this one, and others spoke about relationships with schools, relationships with community organizations, the connection with community to allow more tailored public health interventions and messaging. And then others spoke about the sharing of resources where municipal governments as key partners in local public health were able to provide space and personnel, funding quickly to support the local public health response. And then the second and final theme around the sort of enabling factors was related to this strong local presence and leadership and the dedicated public health workforce that together kind of allowed for a nimbleness, this ability to react and respond. And so one key informant spoke to how our medical officer of health established the Health Emergency Operations Center, where they're the decision maker and they didn't need to go through our regular bureaucratic processes of approval. And the other spoke to how this kind of strong local leadership was able to sort of overcome some of the challenges and weaknesses that were seen at the provincial level, where they remarked that communication out of the province has been muddled and difficult to follow and sometimes late, whereas we've been able to be what we hope is the primary source of information to the people in our community. And then several key informants spoke to the commitment, the dedication, the skills of the public health workforce in enabling the response, enabling the connections with community and intersectoral partners that were necessary during the response. So to summarize, that was sort of a snapshot of where we're at and what we're finding. And I hope I was able to convey some of the, insights that we're gleaning from these case studies and these interviews. So what's interesting to me is that some of these emerging findings really echo some earlier studies of the public health system. So you might not be shocked to hear these. But, for example, the 2017 expert review of public health in Ontario noted some of these same strengths of local presence, relationship with municipalities, and collaborative relationships, as well as some of the weaknesses around limited coordination, the lack of alignment with LINs at the time that made it challenging to collaborate. And so what we're seeing is, an echoing of some of these same challenges that even in the 2017 review, these were echoing earlier findings from earlier reviews. So I'm really excited for and sort of, seeing how some of these some of these strengths and weaknesses might be unique to Ontario, whereas some might be shared with other jurisdictions. And so that brings me to the next steps, where we're excited to be having done almost 18 interviews in Quebec already, moving on to Ontario. And these are three different unique contexts where you can really look in depth at some of those, the ways in which the organization, the governance, financing, the major structural changes that have happened in both Quebec and Alberta have impacted the public health functions broadly, but also the pandemic response specifically. And then in future work, I note a few examples of where this work could go, such as learning from and about Indigenous self-governed public health systems, and to fill some of the gaps in data and comparability of data across the jurisdictions, as well as to hear from perspectives from other stakeholders. We took a pretty narrow lens of leaders in public health, organizations and units, and the sort of key recipients of the public health, that small public health budget within Ministry of Health. But we know that partnerships are essential to public health, and that these views from other stakeholders across the other sides of these partnerships will be really helpful in understanding how these system structures impact public health, and what are some of the features of those strong partnerships that we need to preserve and maintain as governments continue to reform and aim to improve their health systems more broadly. So I think I'll leave it at that, and I hope I've been on time. And I'll just...
Not only have you been on time, you've been perfectly on time.
That was a miracle.
35 and a half minutes, according to my watch. So beyond being on time, you've also done a tremendous job in presenting a huge amount of material and introducing all of us to the complexities of the public health systems in Canada. We know that you weren't able to bring all of that information in front of us, but you've given us a really good taste. So as mentioned earlier, I'm going to serve as the faculty discussant today. I'm going to get right into my remarks. So I've got a bunch of questions that I'm going to pose. And Sarah, I don't actually expect you to answer them. You may answer one or two of them, but they're more to spur some of the thinking amongst the participants today. The first one has to do with the part of the study that you're not really focusing on today, which is the reforms, right? So, the study initially set out to understand, what's happened with public health system reforms across Canada, and, what are the benefits of the reforms in different provinces. My question is this, and we've seen, I think, quite a bit of reforming happening over the past few decades. What has spurred those reforms? Like what's caused provinces to adopt those? Like, these are major policy changes. So is it because they identified huge problems? Was it more political in nature? Is it a combination of these things? Is it because, in some cases you might say, if it ain't broke, don't fix it. So was it being perceived as being broken? And I mean, part of that is that I think some of the provinces have gone back and forth a bit. All right, so I know Alberta had this huge, very dispersed system, and then they centralized and they decentralized a bit, and I think they came back to being very highly centralized. So that's one set of questions around, like, what spurs the reforms in public health systems at the provincial level. The second one is, and you didn't get into this today, how do we assess success? And I know that there is a component of the study talking about performance measurement, but really, like, at the bottom of it, we want to know which configuration of public health systems is going to bring about the best results in different contexts. So that's understanding that one size doesn't fit all. But how do we know, right? So what are the outcomes that we should be looking at? Right, one of them that you talked about today is how successful were provinces in dealing with COVID-19, or how successful were individual public health units within provinces at dealing with COVID-19. But how do you disentangle the effects of the system on that versus other things? And this leads me to a third question, which is, and you alluded to it in one of your later slides, what is the effect of individuals and leadership? Right, so there was a piece, I think in the Toronto Star this week or last week about Kingston, where Kingston had only one death related to COVID-19. And it, related it to a bunch of things that the public health unit, led by the medical officer of health, did in Kingston versus other places. Now, the public health system of Kingston is, similar to that of other public health units in Ontario. I know we have 3 different kinds, et cetera, but so what is the role of leadership? And people talk about this all the time with Bonnie Henry in British Columbia versus, say, David Williams in Ontario, etc. Finally, and I'll leave it at this. Are you applying, or have you seen a critical lens applied here? So in COVID-19, the effects of COVID-19 on Black people, other people of color, Indigenous people, people at the lower end of the SES spectrum has been huge in comparison. Do we have a fundamental problem in the power structures of our public health systems that are not addressing sufficiently the real deep issues of equity that we have? So again, I'm going to leave it there. Those are just some thoughts that come. This is a huge topic. I don't expect you to have answers to everything, but I would encourage other participants to perhaps use these in addition to your own thoughts to stimulate some thinking and some discussion about this. I'm going to turn now to Harman Sandhu, who's our trainee discussant.
Thanks, Rob. So hard to follow those multiple questions, complex, difficult questions, and best of luck to Sara for keeping track of everything that we're saying, which I'm sure is a challenge as well. So first of all, thank you so much for your presentation, Sara and Rob, for giving me the opportunity to share some remarks as a student discussant. It's a really unique opportunity because I'm involved in this project as a research assistant and have been conducting and contributing to the interviews in Ontario and the subsequent data analysis. But what I hope to do with my remarks is situate the students and everyone else in the broader field of inquiry that this work fits into, hopefully in order to stimulate some more thinking. And then I have a very broad question I'll share at the end. So Scutchfield and colleagues in 2009 defined public health systems and services research, or PHSSR, as a field of study that examines the organization, financing, and delivery of public health services within communities and the impacts of those services. And then Thomas and colleagues in 2015 expanded on the definition by proposing that PHSSR provides the evidence and scientific foundation for increasing our understanding of public health systems, supporting health system improvements, and then advancing the field of public health practice. I want to note that these scholars are based in the US, and much of the prominent literature in this field comes from either US settings and to a certain extent Europe as well. And in fact, the National Association of County and City Health Officials, or NACHO, conducts nationwide surveys and creates profiles of local health departments in the US. In contrast, the last systematic pan-Canadian research agenda in this field was published over a decade ago by Strocher and colleagues, and I'm unaware of any recent agenda settings in this field of research that's been taken place since then. And my own kind of informal, rapid search of the literature suggests that in Canada, topics in system leadership, integration, multi-sectoral partnerships, and system financing have advanced since that time. However, many gaps remain. Some of the ones that were mentioned by Sara in the presentation as well. So Faisett, Laniel, and colleagues in a 2020 study looked at how public health budgets have not kept up with the growth seen in direct health and social services investments in Quebec. They also noted that transparent and comparable public health system financing data doesn't really exist at the provincial and territorial levels in Canada. Furthermore, kind of expanding on that work by Fafard and colleagues in 2018, there is differences between the role of Chief Medical Officer of Health across Canada. And I think it's worth thinking about who is best positioned to be leading and coordinating a COVID-19 response. Should it be public health system leaders at provincial levels who might be subject matter experts or immersed in the field, or political leaders who might be better situated and able to balance the needs of a multifaceted political landscape? And in fact, the Feierlbeck and Hardcastle 2020 reading draws our attention to this interesting tension and lack of clarity between the responsibilities of the Premier and the Chief Medical Officer of Health seen in Ontario's pandemic response. In short, there's a lot of questions to be asking in this field, and I think this project is a significant step towards progressing our understanding of public health systems in Canada. So I have one overarching question that I wanted to propose to Sara first, and then anyone else if they had any thoughts. And so the question is that Feierlbeck and Hardcastle refer to a point made in the Naylor report about how public health emergencies typically lead to a brief flurry of minor investments and reform in public health systems, rather than major structural changes. From the current context in Ontario, what you're seeing from the key informants and what they're saying, living through a major focusing event of COVID-19, and knowing that in Ontario, public health financing and structural reforms were on the government's decision agenda not too long ago. Do you think system level reforms or changes are coming to Ontario and or Canada in the near future? And what do you think they will look like? And on the other hand, are there any changes or directions that you would really like to see? And so I'll leave it at that. Oh, Rob, you're on mute.
Thank you. Thank you, Harmon. Fantastic, and thank you for rooting us in the literature so well. And your punchline really hits home. Sara, I don't know also whether you're able to keep your eye on the chat. You may be better at that than I am, but there have been some complimentary remarks made there, but also a couple of questions posed and comments made. Sara, I want to give you the floor now, just in case you'd like to respond to anything that Harmon said or I said, or anything that's already in the chat. And then I want to open the floor for questions and comments. And, they can be made in the chat. I would encourage trainees in particular to speak out. I know it can be difficult, but it'll make it a bit easier on myself and Sara if you do so through your voice rather than the chat. The chat is also certainly acceptable. Sara?
Thanks, Rob and Harmon. I share all your questions, and so I'm pleased to hear that I don't have to answer them, but I'll give you some thoughts on the last one, because it's really interesting to be kind of playing out. I feel like I'm in Kingdon's framework, because you talked about the focusing event, the decision making. Like we are part of the team creating those policy options so that they're there when government is ready, and they are ready. Like before the pandemic, there was this urgency, like we need to reform the system, and then they sort of slowed down and decided, okay, let's do some more consultation, let's think about it, let's wait till some research can be done, and sort of supporting our team through, at least verbal support of our work, and saying, like, we'd really like to hear the findings of your study. And so there's this receptiveness to the work that we're doing, to reviewing the many expert reviews that have been done. And there is, not only was before the pandemic, but even more so now, this willingness and desire to make major changes. And so, yes, I think there will be. I mean, the extent, like how major they'll be to the public health system specifically, I think it will be one of the biggest changes to public health that we will have seen in a long time. But what it should be is, that question is very hard. I think what we're going to try and provide is a summary of what we're seeing from across Canada, so we can not only speak to current strengths with the Ontario system, which other reports have done, which we're starting to see as well, but also what are the strengths and perceptions of strengths by public health leaders in other jurisdictions. And so we can sort of combine those and seek to provide a more, a review of a broader set of policy options than simply looking at building on what we hope, building on strengths that are here, as opposed to making a complete overhaul of a system that would be yet another shock that puts the system in flux and unable to manage a pandemic, which is what we heard from our first theme that came out of our work. And I see great chat, but I honestly haven't been able to keep up with it. But Greg's is so long, I can't. Maybe he can speak to that one. And Stephanie also had some great comments. So I'm happy to sort of mute myself and hear them say their comments, and also hear from the trainees. Thank
right,
you.
and prior to that, Diane Simon was giving some explanations for what's happened with Indigenous people in COVID, and talking about the jurisdictional challenges that are faced, and the fact that it's federal, provincial, where's the money coming from, and who's responsible, and also the lack of race-based data, or the challenges of collecting that. Diane, am I getting that right? Yeah. Okay.
Yeah, I think one of the big issues right now in terms of even collecting race-based data is having that even pre-conversation and consultation in conjunction with First Nations. So rather than just going ahead and collecting it, that First Nations are part of that process in terms of the identifiers and the interpretation of all that data. It's very complex.
Thank you. I'm going to suggest people, I'm going to try and do if you can raise your hand in the, in the Zoom way, then that'll help me see that. In the meantime, or if somebody just wants to speak out, then first of all, I want to give the trainees a chance. And don't all speak at once, but anybody can start. Julie?
Hi, so thank you very much for the invitation as a previous student or still trainee to watch this presentation. It was very interesting. And I really liked the qualitative kind of pieces of your analysis. One of the things that's kind of come up in other research, not my research, just things I've read, is about using resources, or if participants used any resources related to the SARS pandemic or H1N1, and whether they found that helpful, or whether it was relevant at all for this case. I'm curious to know if any of that came up. Thanks.
Sarah?
Thanks, Julie. Great to see you. And I'm surprised you didn't speak to the public health dentistry role in the pandemic, and how dentists and hygienists have shifted and tried to support the broader public health response. But that could be another discussion. But that's a great question. It did come up in interviews where some previous pandemic experience with partnership and rapid reaction and sort of bringing people together to decision-making tables in reference to SARS and H1N1 that did come up in several interviews. However, others spoke to the plans that had been put forward to update and to strengthen the pandemic plans, having gone through those previous outbreaks and epidemics, and that they hadn't been supported by provincial funding. And so they spoke to how they wish they had had this investment, because they had plans. They proposed these enhancements to their pandemic preparedness plans as a public health unit, but they hadn't been able to do so, and hence were sort of commenting on how that put them in a more precarious position at that point.
Yeah, I'd like to just make a comment on that as well. So just because I'm discussing this time, I get to speak a bit more. It actually is something that I've been researching a bit. I'm very interested in this concept called atrophy of vigilance. I've written about disasters and crises of different sorts. I've been working with Ted Whittick on a piece looking at atrophy of vigilance related to pandemics or previous epidemics. And I mean, it strikes me that, Public Health Agency of Canada and to an extent, Public Health Ontario were established as a direct result of SARS. If we look at a public health system, those are important components of the public health system. And Public Health Ontario certainly was meant to make a big difference in Ontario's public health system. And, so it makes me think, okay, did they make the difference that they should have made? Okay, why not? And was it because, right after SARS 10 years ago, more? We were really worried about this stuff, and so we put the funding in, and we created those pandemic plans. Everybody did, and they were up to date, and we financed them. But time went on. Maybe it's a matter of governments that came in that were less prone to, that are more prone to small governments, and wanted to decrease the investments. But I think this is a crucial point for the reforms of public health systems, because if they're going to be reformed in a way that's going to make a difference, a good difference, what would it take besides a focusing event like COVID? Where so much has gone wrong in order to make real change happen. It's a great question, truly. I don't have an answer, but I think atrophy of vigilance is one lens that can be applied to understanding what happened. How do you create institutions to prevent the atrophy? To actually, so there be real learning, deep learning now to make the significant changes that are needed, it seems, and then to maintain that. It's the billion-dollar question. Stephanie and then Sterling.
Hi, thank you so much for sharing your research. I guess just going on, following in regards to Rob's comment, I guess one of my biggest frustration of working in healthcare is I'm noticing that a lot of the decisions that are made, like the comment I made was that, oftentimes decisions are made in terms of, like, for instance, with CCAC turning into the Allin, and then now we're looking into the Ontario Health teams. I find that as a frontline employee, a lot of the times there's so many gaps that we notice while working in frontline, and there's so much duplication in services, but there's always decisions made at more, senior level. And there's so much that, if there was a more thorough needs assessment done, I think there's so much that's value to gain from that. But at the same time, it just doesn't seem that it will ever be considered, or there's just a challenge to get those voices heard, and for all that important knowledge to be shared, so that it influences decision making. And I'm just wondering, like, what are your thoughts in terms of, like, how can we, influence the changes? And I find that there's so much that we can improve in the system, but a lot of it is so political. So it's just so difficult. And that was part of the reason why I even got into this collaborative program, because I was getting so frustrated noticing all the gaps, and I could see, and I just wanted to understand what is going on, how can we improve the system? And I guess, now that I've taken CHL 5300, I'm noticing the political aspect, which I was sort of oblivious to, and I understand the challenges, but I'm still sort of listening to you, and I find I'm not really sure how can we improve the system. So I don't know if you have any thoughts on that. And I know it's kind of a big question, I guess.
I think that's a great question, Stephanie. And as you're talking, I'm thinking about, like, the model of research that we've tried to take in this study, which is, like, integrated knowledge translation. So you bring in the people who can make decisions, so they can influence the political decisions because they're part of the bureaucracy that then draws up the plans and has that influence. You work with them closely at the beginning of the project, help shape the questions that we're asking. You engage them throughout the process so they feel like they're, helping to contribute to the work, that you're relaying findings and sharing your learnings on an ongoing basis, and then you sort of structure some of your outputs to, in the format that they are looking for, in order to share what we're learning from people on the ground, closer to the ground than I am, but not maybe frontline providers. Some of the groups you're talking about we may likely have missed, but at least communicating the findings, the themes that come from interviews with people who are making decisions at the local level, and then bringing those findings to decision makers. And so I think that's the model where, we can share what we're learning and do, as you're saying, like a needs assessment, but this is a different type of work where you're trying to draw out those strengths and challenges and then inform the decision makers who then have to weigh this with other priorities and make those trade-offs. But that's sort of my best response to your very challenging big question, and something that we need to think of in all our research.
Thank you.
Yeah, I would just add quickly that, there isn't a lot of research here, as pointed out by Harmon and Sara during their presentations. The fact that CIHR actually initiated this call, it was not investigator initiated, is a sign that somebody's looking to do that. And I think that we do need research evidence as one of the inputs into the policy process. It doesn't mean that the policy is going to change in the way that the evidence from this project comes up. And this is a tiny project. I mean, it's $200,000, I think, over 2 years. So, we're not going to move the needle too far with this, but it should be the beginning. And Sara should get a huge grant to do a lot more work. Sterling.
Thanks. Hi, everyone. Thanks so much, Sara, for sharing this project. It's really interesting to hear about. I guess I'm curious. I'm currently supporting the COVID response at one of the public health units. And I'm curious, when you spoke about the way that some are working collaboratively and in conversations with each other, my understanding is that really MOHs and public health units have a considerable amount of control over what specifically happens in their public health unit, and whether, taking sort of an Ontario focus, what sort of best practices or collaboration are happening organizationally across public health units, and if there's any sort of level of information sharing or best practices, because my understanding is that it's varied a lot, even just specific to COVID, what different public health units have done, and different data entry processes and timelines and everything like that, all sort of like meeting the ministry's criteria, but really shifting depending on context. So I'm curious about that, and maybe also picking up on that organizational question. I'll just maybe flag a question further up in the chat from Kate Mulligan that is also asking about the role of boards of health, and if boards of health have played out in this organization as well. So maybe tying those in together would make sense. So thanks.
Thanks, Sterling. Those are great questions, and I wish I had like a clearly formulated answer, but what you're saying reminds me of lots of the different quotes and interviews that we have that spoke to many examples of the types of sharing and learning across public health units that were either had, because of existing relationships or because of, new tables that they had joined, and then were able to sort of speak to some examples, for instance, of where there had been surging cases in one public health unit and they were able to bring people from another public health unit. This also speaks to one of the questions in the chat around repurposing public health personnel from parts of the public health system that were, for instance, school-based programs that had closed. They didn't want people going into schools. Schools were either closed or they didn't want any humans entering. So then public health nurses from schools were brought into case and contact management. And then, so there's many examples of that as well, both within public health units and across. And on the information and technology side, there was examples raised of how data systems were developed really quickly and then shared with other units before the central case and contact management system was done. There was sort of these, everyone was doing it for themselves, but at least sort of 6 or 7 public health units then migrated to one that had been shown to be promising. So there was, again, an example of how this learning is taking place in the absence of a structure or a formal process. This was happening, but it was only by through the strong leadership, through the existing relationships, through the existing kind of, the informal structures that were either in place before or in response to the pandemic. And so in terms of boards of health, there were some other examples of how public health leaders were speaking to how the budgets coming from the region that were able to sort of pull in from other parts of the regional government really quickly. So people who were working in other, outside public health were all put into public health because this is a single entity, so that it was really easy to shift funding at the regional level. And then there was a hope that eventually the provinces would then, help to cover the shortfall, but at least they were able to fund things really quickly because of that regional governance. And then I haven't looked at the data specifically at the Board of Health level, but there was sort of on the one hand, on the other hand story. So you hear from some that are like fully integrated, that it's really helpful that public health is integrated into the budgets of the regions and it's able to be more flexible. On the other hand, you hear public health leaders saying, ours is an individual budget just for public health. It's protected. We don't have to fight for our public health dollars. So it's not a clear story. It seems to be there's both, you hear both sides of that, but I haven't looked into it specifically, but you raised great questions.
Thank you, Sarah. So I am going to open the floor now, just a heads up to anybody who would like to pose a question or a comment. The chat has been quite active, and forgive me, I'm not able to pick everything up out of the chat, but there are a couple of people interested in the clinical public health perspective. Michael Snyder asks, can anyone speak to the clinical public health approach within the public health system reform context? We speak of bridging the gap between primary care and public health, and I'm curious to know if public health, I'm curious to know if clinical public health approaches have been interwoven with this research, and in this research, is this research involving the response to COVID-19 in particular? Sarah, can you speak to that at all?
Only conceptually. So what's informed this work is this, we are aware of this, that initial conceptualization I showed you that has public health systems, healthcare systems, and then there's this crossover. And I think clinical public health is that one of those areas where it's crossed over, and it hasn't featured prominently in our case studies because we've been focusing on that core sort of what is within exclusive to public health system versus the crossover. So I think that would be a nice extension, but it hasn't been a core focus of our case study in Ontario or Quebec yet. But so I'm curious to hear thoughts from others on how they think that could be better integrated.
Okay, so the floor is open. I don't see any raised hands. Anybody want to speak up at this point? Michael Rackless has been making some comments in the chat box. Michael, did you want to voice those? I'm guessing not. But,
sorry, Rob, can you hear me?
Okay. Yes, we can.
Yeah, you provoked me. In particular, I was sending a couple of notes to you and Greg applauding what you had said, and sort of taking the longer look back, which is a lot easier as you get older, I guess, that I think some of the key institutions that were put in place are, some of the blinders we don't see. An old friend of mine likes to relate the story of the elephant that's trained as a baby with its legs staked to the ground with a chain. And then when it becomes an adult, it can easily remove the chain, but it doesn't because it's already guided. And I think that some of the decisions where there was a group in the early 70s, even in the Bill Davis government, which was somewhat reformist, to implement OHIP as a population-based system. The first medical director of OHIP, Dr. Norman Gould, wanted to have physicians have to follow clinical guidelines to get paid, the kinds of things that Kaiser Permanente was doing back then. He was told literally, great quote, just cut the checks, Norman. And then Fraser Mustard, who was a conservative insider in many ways, had this wonderful report in 1974, which recommended the creation of non-voluntary regional health authorities, district health councils. That they were originally supposed to be organizations that would mandate the integration and creation of services, and that physicians would be moved into groups with mandatory groups required at the district level. And as some of you may know, recommendations in Ontario over the last 5 to 10 years for the creation of mandatory clinical groups have also failed. So we failed to implement, our insurance system as more than an insurance system. And then we failed to develop this needs-based planning. We continue to come back at it, thank goodness, on a regular basis. And there clearly are a lot of people in this province who would like to move us in those directions, maybe using Ontario Health or Ontario Health Teams, whatever, as those vehicles. However, I see that there's some of these really strict guidelines, or they're more than guidelines, that keep us in our place, and with a lack of focus for our overall health system on public health, and for the lack of integration and a more preventative approach within our health system. But saying that, I'd love to provoke, if I could, somebody like Greg or you or someone else, Ray's I see maybe on the call, to see what you say about how our institutions may have bound us to where we are today.
Rob, I don't mind jumping in just for a second here. The division between primary care and public health it has been very deep for a long time. And part of it is structure, part of it is attitudes. Certainly in my work in the North, where there was a fair amount of integration in terms of the community health center and tremendous emphasis on upstream care and services, it still stopped at the door of public health. And that is in part because of the desire of the people leading public health in territorial governments, for example, to firmly insist on remaining a separate silo. And that was an attitude that was, I found, quite pronounced just about everywhere I went. And it was also a desire to do a particular type of work that was, in some respects, not particularly risky, and was clearly defined, rather than getting mixed up in the community health centers in some more strategic capacity. And I think that we lost a real possibility in that. So it's more than about structures. It's also about attitudes, and it's on both sides of the fence. It's on the healthcare side and it's on the public health side. And I know that's a controversial perspective, and I know that some of the public health thinkers in the crowd will want to take me to task for that, but I wanted to get that out there.
Thank you, Michael and Greg. I'm not going to pick it up. Sara, did you want to respond to this or jump in? Or Harmon, you're welcome to share your thoughts as well, or anybody else for that matter. It's meant to have a discussion here.
I guess like I would want to, I guess, add another layer maybe to thinking about this from myself, and something that maybe might have come up in this project a little bit as well, mostly maybe minor data points. So I wouldn't say this is like a major theme or anything, but when you look at financing of a broader health system and you look at the amounts of money that these public health systems, as we've defined them, the money that they're getting is typically what I would say is like a tiny portion of what the healthcare system gets. So I think High's measurements, I have this like printed and put up on my board here for easy reference, but 2019, all of the kind of like spending on health, 5.4% of the spending on health was on public health, right? So if you're proposing structural changes, I think that go towards integration of healthcare and public health in a clinical public health approach, public health actors, from their perspective, if I were in their shoes, I'd be concerned that if my kind of voice is 5.4% of the overall voice on the table, am I giving up certain functions and powers by integrating with clinical care? Am I becoming like another kind of like consultant in that case, or am I going to continue to be a leader of my own system that remains separate? So I kind of wanted to add that financing, I think, tells a story, at least that I'm speculating about, where there's an argument for at least public health perspectives to remain separate. However, in theory, I can definitely see a lot of arguments being made for the functions of both a clinical and public health approach to be combined in many ways to actually bring about better improvements in public health.
I see Reza is going to get into the conversation. Please, Reza.
Yeah, I want to apologize. I didn't hear most of the presentation because I was teaching. And I really want to see the papers that you're doing because they sound fantastic. But I think it's important to recognize that public health depends on how you define it. And one of the ongoing lines they make is that if public health is doing its job, it's invisible. You don't see it unless it breaks. So the issues around some of the integration, a lot of what public health is trying to do is make sure problems don't happen in the first place. And that's not the same as treating them after they happen. And also a lot of them are not necessarily going to be in the health budget, you know, like where's water safety and where is food safety and where's all kinds of other things that are important public health issues, but may not necessarily be in a public health budget line. And I apologize if you already covered those.
Thanks, Reza. Okay, I think that we have about 5 minutes left, and there are certainly unanswered questions in the chat. So I'm just going to pause for a second, and anybody whose chat comments or question hasn't been addressed, give you an opportunity to voice it now. Michael Snyder.
Hi, thanks again, Rob, for asking my question earlier, but I did have a question that I did ask earlier in the chat, and that was related to, I heard that registered dietitians at Toronto Public Health specifically are not going to be doing too much of their usual dietetic work in 2021, and I'm just wondering if, I mean, I don't know much specifics about that, I haven't had a chance to really look into that, but I'm just curious to know if any of you can speak to the human resource reallocation, the reallocation of human resources at the municipal level, or like to help in response to COVID-19, just because we do have similar educations being in public health. I mean, everyone has their niches, but in terms of transferable skills and stuff like that, I'm just wondering if that's become a really big focus right now in response to COVID-19, and if that will help with any systems reform maybe in the future. Thanks.
Sara?
Yes, that was a pretty big theme that came out of the interviews in Ontario in terms of the enablers of the response and how a trained public health workforce, whether with specialty in nutrition or in school-based programming or in the work that they're doing in communities, regardless of which background they have. There's a sense of a shared skill set that allows for transferability and was able to be leveraged for the response. And so several leaders of public health did remark on this capacity and nimbleness and the sort of professionalism that was common across all these groups, and was able to move people around with relative was able to move them around in a way that was effective, but also that maintained that same professionalism. But also what came out is that there's this understanding of the importance of community and like relationship with community that they were able to bring from their role to the pandemic response as well, and that was seen as a great strength. So I see this as definitely one of the themes that came out as a strength and enabler of the response in Ontario.
Great. Well,
Thank you.
Oh, sorry, go, Michael.
I just said thank you very much for answering the question. It was a good answer. Thank you.
Great. Sarah, I just want to give you a chance, if you'd like, if you have any concluding remarks.
Just that I hope to come back, share some of the findings from the other studies in the other provinces, as well as some ongoing work I have on the public health finance side, because I agree this question of how much we are spending and how comparable that is in terms of what's in and what's out is a really important one that I'm actively working on, and hope to be contributing to that evidence generation as well, as Harmon and Reza asked about. So thanks for your support, and I hope I get invited back in next year.
We'll write that down, absolutely. So I want to thank you, Sarah and Harmon, for helping really stimulate our thinking. Sarah, this is no criticism of you. I think we all leave here with more questions than answers. I think that's actually a compliment in this situation. And I would invite, people who are here to get involved and, maybe work under Sarah's leadership to create a large research undertaking to really get at more of these questions. I also want to say it is wonderful for me to see so many former trainees, people who have been involved in the collaborative specialization as students, trainees, faculty members, mentors joining us today. It's a nice feeling. I hope that this was enjoyable, and we hope to see you in future rounds as well. Thank you to all, and we shall reconvene next time. Be well, enjoy that sunshine out there.
Thank you, bye.
Bye-bye.